So once again, my name is Dr. Amber Adams. I'm one of the nurse educators here at bootcamp.com, and once again, we are so happy that you're here with us today. We want to welcome you. We also have Krista in the chat. She is also a nurse educator here at bootcamp.com, so if you have any questions at all, don't hesitate to let her know in that chat. I do want to let you know there is a small chat delay, so whenever I'm asking questions, or if you ask any questions and I don't answer it right away, it's just a little delay in that chat. So we'll make sure we get to y'all. Okay, so once again, this webinar today is on delegation and assignment making questions, which I know can be a very intimidating topic. So before we get started, I do want to briefly mention that we would love it if you would invite your friends or any other cohort members that are also gearing up to take NCLEX to our Facebook page. You can see in the red square that little invite button there. We would love to have everyone join us for the next scheduled webinar. Additionally, these webinars are recorded, so you can watch them later. Okay, so today we are going to be talking about the principles of appropriate delegation and assignment making. We're going to briefly review what the nurse's role is in delegation, and then we're going to talk about the 5 rights of delegation, which is a wonderful resource to help guide you when you're trying to navigate these delegation questions. So the reason I wanted to make sure we talked about delegation and assignment making in a webinar is because management of care topics count for about 18% of the NCLEX, and that's a pretty high percentage. So this management of care section includes delegation, assignment making, and prioritization. So all of these topics can be a little difficult when you're navigating them because it's not quite as simple as some of the other courses where it's focused more on basic patho and just basic patho. So management of care can be quite intimidating, so I want to just remind everybody, if you missed our prioritization webinar we had a couple of weeks ago, it is available on our Facebook page, and it is a wonderful resource to help you navigate prioritization questions. Okay, so once again, it's guaranteed you're going to see these management of care topics on NCLEX, including delegation. And I want to remind everybody that delegation is not as simple as just asking somebody to perform a task. It is a very complex nursing skill that poses a lot of safety risk to our clients as well as to our nursing license if we inappropriately delegate. And it's very frequently used in practice. So before we jump into a couple of practice questions, I want to briefly remind y'all of the delegation roles. So you may hear me use these terms during this webinar, and so delegator is the registered nurse that is asking somebody to perform a task, whereas the delegatee is the person being asked to perform the task. This is another member of the healthcare team, and it's usually a UAP or unlicensed assistive personnel. So there are 2 big things I want you guys to remember, both when you're navigating delegation questions and when you're at the bedside and you're trying to figure out if something is appropriate to delegate. The first is we can never delegate any steps of the nursing process or any task that requires clinical judgment or clinical knowledge. So all those steps of the nursing process, assessment, diagnosis, evaluation, all of them cannot be delegated. That is the registered nurse's job, and it's within our scope of practice. The second rule I want you to remember is only delegate routine tasks for stable clients. So we want to make sure that task has a predictable outcome and that we know that client is stable, where that task isn't going to pose any type of risk to them. And then also, we are going to talk some about assignment making principles today. So it is so important whenever we are navigating delegation and assignment making that we use our resources. But the main 2 we're going to talk about today is scope of practice and the 5 rights of delegation. So before I move on to those, can anybody tell me any of the 5 rights of delegation? Does anyone remember any of them? Oh, I love that. Don't delegate what you can eat. Evaluate, assess, and teach. I love that. I've never heard that. That is really cool and very true. So anyone remember any of those 5 rights of delegation? Right task. Very good. So yes, it's the right task. the right person, the right supervision, very good, right communication, and right circumstances. So very, very good, guys. Looks like y'all are already pros at this. So before we move on to discussing those 5 rights a little bit more, let's briefly talk about a scope of practice. Because in order to know what's appropriate to delegate, and also in order to be able to make appropriate assignments, we have to understand the scope of practice of the different members of the healthcare team. So the first is the registered nurse. So that registered nurse has the largest scope of practice. So as RNs, we have a lot of responsibility. And that's going to be all the steps of the nursing process: assessment, diagnosis, planning, implementation, and evaluation. And we also are responsible for performing those comprehensive assessments, admission assessments, initial assessments, and any education. We want to be the one providing that comprehensive initial education for the client. And then next we have the LVN or the LPN. And they also, of course, are nurses, but they do have a smaller scope of practice, although you don't always see that in practice. Me personally, I was an LVN for a couple of years, and it wasn't uncommon that I would be asked to perform tasks that were technically outside of my scope of practice. So really the LVN, although they perform some parts of the nursing process, they typically should be performing nursing care on stable clients, and they are mainly reinforcing that client education that that registered nurse has already performed. And then lastly, we have the UAP, and that is going to be somebody that's unlicensed, and they usually have the smallest scope of practice. They mainly collect data and implement tasks that are for stable clients. And then once again, they do not provide client education. That is not within their scope of practice and training. So now that we have a pretty good understanding of everybody's scope of practice, it should be a whole lot easier to navigate these questions. So let's briefly talk about the 5 rights of delegation, and then we'll jump into our practice. So the 5 rights of delegation. First one is the right person. Anytime we ask somebody to perform a task, we need to make sure, is the person we're asking have the skills, the knowledge, and are they competent to perform this task? And is it in their scope of practice? So we, once again, wouldn't ask a UAP to perform discharge teaching. Next is right task. So once again, is that task within their scope of practice? And is it a routine task? Or is it an experimental task? Or is it something that we're not quite sure how that client is going to tolerate? If so, let's not delegate it. And does it pose a minimal risk to the client? And then next is right circumstance. So we need to make sure that client is really truly stable, or they are not at high risk for becoming unstable. And are we available as the registered nurse to supervise? So many times delegation is used when we're very busy to make sure client needs are met, but that RN should still be readily available to make sure that they are available to help with that task and make sure it goes well. And we have to make sure all the resources are available. Is the appropriate equipment and staff available? Next is right direction and communication. This one is very important. We have to give very specific instructions. So instead of asking the UAP, will you please let me know if the vitals are abnormal? We would want to say, can you please tell me if the client's systolic blood pressure is above 120? As the registered nurse, you have to be very clear and also give that delegatee an option to ask questions and clarify any information. And then last, right supervision and evaluation. So the RN always needs to follow up on the tasks that they have delegated and make sure that the appropriate outcomes were achieved and make sure that it went well and provide any feedback to that delegatee. So there is one big takeaway I want you guys to remember today, that the RN always remains responsible for client outcomes. And that is why delegation is such an important safety issue, is if we ask somebody to perform a task and that client is harmed or it doesn't go well, we still retain accountability and responsibility as the registered nurse. So we have to be able to delegate appropriately. So I know that was a lot of information, but hopefully now we have a good foundation to help us navigate these questions. So our first practice question. The registered nurse is supervising unlicensed assistive personnel, or UAP. Which task would be most appropriate for the nurse to assign to a UAP? So let's take it one at a time. So the first option, perform incontinence care for a newly admitted client who had a cervical spine injury. So what do you guys think? Should we delegate this task to a UAP? No. Getting a lot of no's. Very good. I agree. So let me talk to you guys about why, for anybody who thinks maybe yes. So incontinence care, although it is typically a routine task, we have a client here who had a cervical spine injury. So whenever we're performing incontinence care, we want to make sure that we are cleaning that client really well to prevent skin breakdown. So we're going to need to clean their back. So what does that entail typically when we're performing incontinence care on a client with a cervical spine injury, or any client? What do we typically have to do to get to that backside? We have to turn them. So with a client with a cervical spine injury, remember, we typically have to use a specialized log roll technique. So if we turn this client with a spinal injury incorrectly, we are going to potentially paralyze that client. So even though incontinence care seems like a routine task, for a client like this, it is a highly risky, non-routine task. Also, I saw a couple people said in the chat that the newly admitted client isn't a good one to delegate on, and I agree with you. Anytime you see newly admitted or just arrived on a question, that is a big red flag that registered nurse needs to be the one who goes and assesses that client and makes sure they're okay before delegating any tasks on them, because we haven't even seen them. We don't know if they're stable. So good job, guys. Next one, assist a client who had an above-the-knee amputation, or AKA, 2 days ago into the prone position. What do you guys think? Would we want to delegate this to a UAP? Sorry, the chats are a little delayed. Yes. Okay, seeing quite a few yeses. And I do agree with you on this. So we once again have a client with an above-the-knee amputation, but the key here is it was 2 days ago. So first off, I want to know, does anybody know why we would put a client that just had an above-the-knee amputation in the prone position? That's just a bonus question. Does anybody remember why? It's a hard one, I guess. It's a challenging question. So after an above-the-knee amputation, they are very good. Somebody said contracture prevention. Very good job. You want to keep those hips extended and straight to prevent flexion contractures. I'm so impressed with y'all. So once again, we lay that client in a prone position 3 to 4 times a day to help prevent flexion contractures with that residual limb. So chances are, if we're on post-op day 2, this client has already been repositioned like this many times. So this is a stable client based on the information we have. There's no indication that they're not, and it's just repositioning. And so it looks like a pretty good option, but let's check the other 2. So option 3, reposition a client with increased intracranial pressure, or increased ICP, who has decreased level of consciousness or altered mental status. So what do you guys think about that? Why would we not want to delegate this task? I'm seeing no, unstable, and I agree with you, because remember, a client with increased intracranial pressure, one of the findings that they are getting worse, or that their condition is worsening, is decreased level of consciousness. So we see that this patient does not seem stable. Furthermore, let's talk about why repositioning is so important with clients with any type of issue with intracranial pressure. What is the quickest way as the nurse to decrease intracranial pressure? What is one of the fastest interventions that we can perform for a client to decrease intracranial pressure? Another bonus question. Repositioning. Excellent, guys. So once again, you want to keep that head of the bed elevated. You also want to keep that neck in a neutral position to facilitate venous drainage. So if that UAP, we already have the client looking really unstable because they're symptomatic. They have decreased level of consciousness. But then if they reposition them where that neck isn't neutral or the head of the bed isn't high enough, they can actually make that condition or that client's condition much worse. So I don't like that idea as something to delegate. Last option, demonstrate use of continuous passive motion for a client who underwent a knee replacement. So CPM, we usually have those the passive CPM devices where that knee joint is made to just move in a stepping position to reduce scar tissue. So what do we think? Do we want to delegate that? And I'm seeing some no's. Somebody tell me why. Why do I not want to delegate that? Education. Excellent, guys. So NCLEX isn't always going to use the word assess or educate. So we have to kind of use our clinical knowledge and judgment. Demonstrating use of something is absolutely education. So this client might be stable, but this is a step of the nursing process. So it is the registered nurse's job to educate that client on that device. So y'all did a phenomenal job on that, and we got that correct. So now let's go to a little bit more challenging one. I know nursing students love SATAs. That's why I wanted to include one in here. So SATA, select all that apply. I know it can be really intimidating when right away you see 7 options pop up on that screen. But remember, we're just gonna make these be like true or false. We're gonna go one at a time and just say true or false, and it makes it so much more simple. So let's take a look. The nurse is caring for 5 clients on a telemetry unit, so very busy day as a nurse. So which of the following client needs can the nurse delegate to an unlicensed assistive personnel or UAP? So once again, let's just take it one at a time. So option 1, determining the pain level for a client that just received IV morphine. So what do you guys think? Should we delegate this to a UAP? I'm seeing a lot of no's. Y'all are super smart. I'm super impressed. So I agree. False. Very good. False. We're treating it as true or false, like I said. So even though determining a pain level or asking a client, hey, what's your pain level when getting vital signs can sometimes be an appropriate task to delegate, the key word here is they just received IV morphine. So anytime we give a pain medication and we go back and ask somebody, what's your pain level? What are we really doing? Somebody just said it, assessment. We're assessing and we're also evaluating effectiveness of the care plan. So that is not something we can delegate because that is a step of the nursing process. So next, assessing a client's ability to swallow food prior to feeding them lunch. So what do we think? No. So once again, this is a little bit easier here because it straight up says assessing. Now, it's not always going to be as straightforward as that, but anytime you see assessing like that, and once again, a UAP cannot assess, that's part of the nursing process. So that would be the nurse's job to go determine if that client can swallow food, and then if they know that that client can, then it would be appropriate to delegate feeding them to the UAP. So we don't like that one. Assisting a client admitted with pancreatitis to ambulate to the restroom. What do you guys think? True or false? Or yes or no? Rescinda, you're correct. Barium swallow tests are a lot of times done by speech therapists, but sometimes, as nurses, we'll perform dysphagia screen and just have the client try to swallow. So very good though. So I'm seeing a lot of yeses for option 3, and I agree with you. We have this client with pancreatitis, inflammation of the pancreas. A lot of times you just have nausea, some vomiting, pain, not a lot of mobility issues typically, and we are just helping them to the restroom. Now I'm going to take this moment to remind you guys, it is so tempting with prioritization and delegation and those type of topics to add information into options and overthink them. Don't do it, okay? So based on what it says, this is just a stable client with pancreatitis. Let's not overread. So option 4, assisting a client with an MI to perform oral hygiene. What do you guys think? True. Yeah, I love it. So once again, don't overthink and see myocardial infarction because that is an intimidating diagnosis. But all we're doing is performing oral hygiene, and there's nothing to indicate that that client is unstable. So I love it. Performing pericare on a client with indwelling urinary catheter. What do you guys think of that? See some yeses. So yes, pericare, routine task, and there is nothing to indicate this client is unstable. They do have an indwelling urinary catheter in place, but that's okay. Now let me give you an example of when this would be false. If it said maybe performing pericare on a client with an indwelling urinary catheter in place with blood at the urinary meatus, or with bladder distension, or with no urine output for 12 hours, something like that, we are not delegating. The nurse is going to go assess them. So option 6, recording intake and output for a client with a history of CHF. Yeah, very good point. Or suspected UTI, maybe. It's a good point. So I'm seeing some yeses to option 6, that y'all think it is appropriate for that UAP to collect intake and output on a client with CHF, and I agree. Great job. Now, once again, let me give you an example of when this might not be the case. Maybe we have a client with CHF who has flash pulmonary edema, or they have pink frothy sputum, and we know with those findings, we should be worried about fluid volume overload, and that nurse needs to be the one who's checking that intake and output because we have an unstable client. So last option, we finally made it. Performing vital signs on a client that just returned from the cardiac catheterization unit, or also known as the cath lab. What do you guys think? Okay, so this one I'm seeing some yeses and nos, so very good. That's why we're here today, because these can be really challenging questions. So this would actually not be appropriate to delegate, but let me explain why. Usually vital signs is a very routine task that the UAP helps us with a lot. However, anytime a client has just returned from a procedure of any kind, they are at high risk for complications. So they're at an unstable time of their care. Also, when we're looking at a client that went to cath lab, we just manipulated that cardiac tissue, either to open up any arteries that are blocked or just to assess arterial blood flow. So that client's at high risk for bleeding, arrhythmias, all kinds of things that can impact perfusion. So anytime you see a question like this where a client just came back from a procedure, the registered nurse needs to be the one to perform the initial vitals and assessment to make sure that client is in fact stable and not showing any signs of complications. So I know that was a lot, guys, and you all did wonderful. Okay, so let's do one more practice question, and let's shift gears just a tiny bit. A lot of times people are more familiar with delegation over assignment making, but you still sometimes will see assignment making on the NCLEX. So let's talk about this. We have a charge nurse who is making client assignments for a critical care step-down unit, which is usually like a step down from ICU. Says which client would be most appropriate to assign to a new grad RN. And I know some of y'all might be thinking right now, you said earlier the RN scope of practice was they can care for anyone. And you're right. We can care as registered nurses for the most complex of care plans. But remember, NCLEX has perfect staffing, so we can be really selective whenever we're making staffing assignments. So it's saying most appropriate. So even though, once again, the new grad RN can care for any of these clients, we need to figure out which one would be best. So let's look at our first option. A client admitted for diabetic ketoacidosis, or DKA, that is on an insulin drip or IV insulin. What do you think? Oh, y'all all are telling me the answer to the question. Y'all want to go at 3. I agree with y'all, but let's talk about why the other options are incorrect. So diabetic ketoacidosis increases the risk for electrolyte abnormalities and metabolic abnormalities, especially, remember, when we're administering the IV insulin, we're going to see shifts in potassium. So that client's at really high risk for arrhythmias and life-threatening complications. So you really want a more experienced nurse that's familiar with DKA protocols and IV insulin. Because once again, IV insulin is one of the highest risk medications we can give as a nurse. If we accidentally bolus it, we have a high risk for client mortality. So this should really be a more experienced nurse if we can help it. The next one, a client scheduled for discharge today that has a new colostomy. So they sound really stable because they're going home today. Can anyone tell me why would I not want to assign this to the new grad nurse, especially if they're stable enough to go home? Y'all are saying no. Teaching, excellent job. So this is going to be a really complex teaching. We want a nurse that has some specialized knowledge on colostomy care and dietary restrictions so that this client has the best outcomes long term and has a reduced risk for complications. So I agree with y'all. Option 2 should probably go to a more experienced nurse. So I know y'all are all telling me option 3 because y'all are all super smart, and y'all are correct. So we have a client with a postoperative infection receiving IV antibiotics. So let's talk about that care plan. That's not really typically a complex care plan because we're mainly doing vital signs, administering IV antibiotics, assessing that infection site, and that's something that hopefully that new grad RN feels very comfortable doing, and so it won't pose a lot of risk to the client or the nurse. However, if we had it, for example, a client with a postoperative infection, that it's experiencing hypotension, they have an elevated lactic acid level, they're tachycardic, what would we think is maybe going on with them? A client with an infection, with an elevated lactic acid level, with hypotension. Another bonus question. Very common but dangerous complications. Sepsis, very good, guys. So in that case, we would not want to do the new grad registered nurse because that typically requires hemodynamic monitoring, vasopressors, all those types of things. And then the very last option is a client scheduled for a pacemaker insertion. And once again, that's going to require a lot of education. Also, this client's going to be at high risk when they come back for, once again, complications related to the procedure. This includes arrhythmias, bleeding. So we're going to need to be closely monitoring that client's ECG reading to check their rate and their rhythm. So we would want a nurse with a lot of rhythm interpretation experience and cardiac experience. Can you ask us? I promise you there's a lot of hard questions in our Q bank, I promise. So option 3 is correct. Great job, guys. So once again, it is a guarantee you're going to see these management of care topics on NCLEX, including delegation, assignment making, and prioritization. We have a lot of great resources for this area because I know it can be an intimidating area that you may not be as familiar with. Once again, delegation is a huge safety issue. So yes, I want you to be able to do great on delegation questions, but more importantly, I want you to be able to be at the bedside and be thinking of these 5 rights of delegation and be a safe nurse that protects your license. So it's so important to continuously be practicing this delegation information. So remember, we are never delegating the nursing process or any task that requires clinical judgment or clinical knowledge. We are also only delegating routine tasks for stable clients. So I am going to show y'all, please follow us on our socials. I'm going to give anybody an opportunity to post some questions if you had any questions about any questions we went through today or just about delegation. But while you're typing those in, since there's a little delay, I want to briefly show you the bootcamp.com website. So all you do is go to bootcamp.com/NCLEX. And this right here is our website. Please check it out. We have a lot of resources we've worked really hard on as experienced nurse educators to try to prepare you for NCLEX. You can just hit start studying for free, and right away you have access to some of the case studies that very closely mirror the NCLEX case studies. And I know these can be quite intimidating. And somebody said they wanted harder questions. I promise you the case studies are quite the challenge, and we have a lot of great practice wins here. You can hit start, and right away you can see these really well-developed complex cases that are going to very closely mirror what you're going to see on NCLEX. So please check us out at bootcamp.com/NCLEX. Let me erase my little mark that I created. And once again, please follow us on all our socials. Can you delegate to UAP the last vital signs before surgery? That's a great question, Mark. Typically, you as a registered nurse want to assess your client before they leave in case there's any complications, and also to make sure that the client is stable to go. Okay. Any other questions? I want to thank y'all. Y'all were like so awesome. I love the participation. It makes it much more fun for me. And I really hope that this information helped y'all and y'all feel a little more comfortable with this topic now. Okay, guys. Well, I hope you join us next week for our next webinar, and I hope you all have a great rest of your day and good luck on NCLEX.